morning, ladies and gentlemen, and thank you very much for the opportunity to address you today in what is has to be Ireland's leading primary care centre. Cork has led the way with Tom Callaghan in Mitchelstown as well, and his new health centre there as well, our primary care centre. I suppose we all live in the real world and we can't deny the realities around us. And the Chinese are reputed to have a curse, may you live in interesting times. And we certainly do. And certainly it's been an extremely very interesting economic time. And that's had a knock-on effect on every aspect of Irish life over the last number of years. But those interesting times are not going to stop this government from introducing a better and more efficient healthcare system. A single-tier health system based on medical need and not on the ability of a person to pay. And there is a precedent for this. Our next door neighbours have done this. And when did they do it? They did it when they stood in the midst of the rubble of post-Second World War Britain. And still there were people there who had the energy and the vision to develop an NHS that is still, for all its faults today, a hell of a system, and one of which they are extremely proud, to the point that it featured majorly in the opening ceremony of their Olympics. So that's what we want in Ireland. That's the way it should be here, and that's the way it will be. Legislation to reform the governance of the HSE is currently making its way through the Oireachtas. The new structures will focus on the delivery of key services and greater transparency around funding, service delivery and accountability. And heading up those structures will be national directors, one of whom will have responsibility for primary care. We'll have a director of primary care for the first time, and they'll be tasked with establishing clear service delivery structures and funding arrangements. And I think that's critically important, that we've clear line of sight across our funding, so that money that is meant for primary care goes to primary care, money for hospitals goes to hospitals, money for mental health goes to mental health, and money for palliative care goes to palliative care, and not what happened in the past. And that's, I suppose, what I want done, and what the Director of Primary Care to do is a lot more than that. I want them to reposition primary care, to hammer home by action that primary care is an essential component of the health reform process. A developed primary care system, we know, can meet 95% of people's health needs. And to date, the primary care strategy and new direction has been the blueprint for development of primary care services in Ireland, and a key aim of that strategy is the development of primary care teams. And those teams have taken far too long to make real. I know we hear figures of 485 and 400 plus and 500. The reality is that about a third of our primary care teams are functioning and delivering for patients. There's another third that are in process and another third that are just very much in the early stages. And I don't believe in coming to conferences like this and telling people like you who work so hard on the front line that things are not what they really are. So I acknowledge that we have a huge amount of work to do and a huge amount of investment to make, and more jobs to bring into allied care professionals in primary care, and we're determined to do it. And on my way down here today, I spoke with the Minister for Primary Care, Mr. Alex White, and we are both 100% committed to bringing the extra posts into primary care that we have planned. I want to say that we're as committed as we can be to having as many as possible of these primary care teams operational by the end of the year, and we will continue to work on this. The teams will work in shared premises, and we're better to make a statement like this than here in Mallow. And I mean, all international research shows that shared premises encourage and facilitate interaction across all healthcare professionals. And that's why we're committed to developing a network of new primary care centres. We know that there are many instances where that interaction that occurs in a casual way in the corridors, in the canteen, can often lead to huge benefits for patients. And that's the sort of thing that primary care centres, bringing all the allied professionals together, can really bring to the table. And this primary care centre here in Mallow, as I've said, is the perfect example of what can be achieved. A perfect example of what can happen when vision is matched by determination. Enhancing and expanding our capacity in the primary care sector is critical if we are to deliver a proactive, joined-up approach to the management of our nation's health. This is particularly important in light of the very significant challenge posed to the health services in the 21st century by the increase in the incidence of chronic disease, ageing population and contracting budgets. The HSE is developing chronic disease programmes which are particularly relevant to primary care. Diabetes, stroke, heart failure, asthma and chronic obstructive pulmonary disease are to mention but a few. And the general practice needs to have an input into this. I don't believe that these programmes, which have been developed mainly in the hospital with some primary care input, can be complete without full matching input from primary care physicians. And that's why I'm so anxious to see the appointment of a director, a clinical director for primary care. The diabetes programme, as you know, is due to commence in the coming months, and the model of care for the integrated care diabetes packages prescribes that uncomplicated type 2 diabetes patients will be managed in primary care only. Patients with complicated type 2 diabetes, as defined by the national model of diabetes care, will be managed by both primary and secondary care. And all patients with type 1 diabetes, genetic causes of diabetes, secondary causes of diabetes, post-transplant diabetes and pregnancy and diabetes will be managed in secondary care only. A national steering committee has been set up to oversee the implementation of the diabetes programme, and it's working through a number of key issues, including the progression of ICT development and identification of drug savings. And I know that here again in Mallow you have a highly skilled individual in the form of Carl Breen when it comes to IT and developing new models and projects for general practice that will aid and abet our care of patients. One of the biggest problems, one of the greatest causes of waste too in the system, in my view, is this habit of repeating tests when a patient comes to hospital, and those tests may have only been done a couple of weeks ago by the GP, or indeed done in another hospital. So to have those results available can overcome a lot of delay and save the patient a lot of discomfort and save the state a lot of money. So we are, in a more general way within the HSE, starting a new IT strategy to help us address all these issues, and certainly all our newer hospitals will be paperless. But we have a big problem, as you know, in that many parts of the system have developed on their own different types of software that don't talk to each other. So we're working on ensuring that that problem is overcome. And it's only when you have access to the information that you can see whether or not what you're doing is what you should be doing. And I've made this point at other meetings, and I think it's appropriate to make it here. In hospitals, we now have developed very good measures of outcome. So we can measure what hospitals are doing. We can see what they're doing that improves things, and we can see other activity they're engaged in that isn't improving things, and discourage it and put the focus back where it needs to be. And I've said, you know, I believe that the fact you can see a GP within 24 hours in this country must improve outcomes for patients, but I can't prove it. And I need to be able to prove it. And we need to work on models that allow us show what improves outcomes for patients and what doesn't. And that will allow primary care physicians and allied care professionals to focus on the areas where they can improve outcomes, and perhaps less so in other areas where they don't. And I believe that when we have those models developed, we'll see the real value of primary care in a much more clear way than maybe has been realised in the past. But coming back to the diabetes, we have given approval to the HSE for the recruitment of 17 integrated care diabetes nurse specialists to support the phased rollout of the diabetes programme, and interviews are being held for these posts next week. One of the few aspects of the public health system where there's a consensus on is the fact that public expenditure on drugs is way too high. The cost of drugs provided to patients under the GMS and other community drug schemes has increased significantly over the last decade in Ireland. Year on year, our increase on spending on medicines is amongst the highest in Europe. In 1998, we spent just under 400 million euro on drugs. In 2009, that expenditure had increased to over 2 billion. And clearly that's not sustainable. It has to be tackled, and it has been tackled. And expenditure was reduced in 2010 and 2011, and indeed we now have a new EFA agreement as well, which will save us over 400 million. Now, I know there are factors that drive increases in expenditure on drugs. The number of items prescribed has increased in the past decade from approximately 30 million items to approximately 70 million items in 2010. GPs are prescribing newer, more expensive products, and greater numbers of people are eligible for medical cards. But my department at the HSE have started to control expenditure through ongoing off-patent price cuts agreed with pharmaceutical manufacturers, and the pricing mechanism for new products has been changed. We now have a review mechanism that takes account of price reductions in other countries. And as you know, I did announce the new EFA agreement, and I've already mentioned the 400 million. But what this really means is a significant reduction for patients in the cost of drugs, a lowering of the drugs bill for the state, greater access to new cutting-edge drugs for certain conditions, and an easing of financial pressures on the health services into the future. But another thing that we are now working on with the Chief Medical Officer is a new methodology for agreeing the entry of new drugs, and a new group to be set up that involves the pharmaceutical industry, the patients, the people who use them, the drugs, the department as policymakers, politicians, and clinicians. Clinicians have a serious role in this. There is a limited pot of money that we have that we can spend on medication, and if we want to have new drugs brought in, then some of the older drugs have to make room for this, because we have a finite amount of money, and the old days of prescribing without any regard to cost really have to cease. And I know that we're working also on a new initiative within the PCRS in relation to 6 pharmacists have come in who are now going to review prescribing and advise GPs on prescribing patterns and how we can improve things for the patient and for the state. In other words, if I, James Reilly, am on a number of medications for my conditions, many here would say it's incurable anyway, but it could be costing 400 a month. Well, the pharmacist may be able to advise in a way that that can be achieved for 200 a month, giving the patient the very same benefit, but saving money for the state, which is then used to give more patients other treatments. And I think that's an area that we have to address aggressively. I mean, we all know that there's some rather crude ways of addressing the prescribing habits of GPs and measuring, using that as a measurement of quality in practice. If a doctor is prescribing a lot of painkillers and a lot of antibiotics as opposed to a lot of drugs for high blood pressure and inhalers for asthma, well, it's a fair bet that they're not prescribing for illness, they're prescribing for symptoms, and I don't think most informed GPs would want to be found to be in that category. So I think there are much we can do in relation to this, and much more ways to go. And we did have a scheme years ago where GPs were able to benefit in terms of investment in their practice, and I think we need to look at all that again. But I want to say about primary care itself and the way that the whole system has worked. The underlying principle that I've always ascribed to is that the patient should be looked after at the lowest level of complexity, that's safe, timely, efficient, and as close to home as possible. Now, there's nowhere closer to home than in the home, and the next closest is your local primary care centre, your local GP. And really, the models of care that we've had in the past are very dysfunctional in many respects. We have hospital consultants looking after patients that GPs could be looking after. We have GPs doing work that could be better done by practice nurses. We have nurses doing work that could be done by healthcare assistants. We have other situations where we've seen orthopaedics, here again in Cork and St Mary's, where they did a study, 50% of the patients, having screened them all, going to the orthopaedic service, were able to be looked after by the physiotherapist. They didn't need to see the orthopaedic surgeon at all. So all these initiatives can yield much better care for patients, much more appropriate care for patients, much more efficient care for patients, and much less cost to the state. But really, at the end of all of this, the journey of reform is about improving the patient journey. Health needs change and evolve only our health system must change and evolve to match those needs. We're now on the way to becoming the modern health service a modern society needs. We're reforming the system for the benefit of patients, and it has to be about patients first, patients centrally. If we don't improve the lot of the patient, the journey of the patient, the outcome for the patient, it doesn't matter how eloquently it's delivered or how elegantly it's designed, it's worthless in my view. I've outlined some of the significant reforms this government has begun to implement and the progress we have made so far, and further debate and discussions like today are useful in advancing the health reform agenda. And I have to tell you, I'm very pleased to tell you, that yesterday at Cabinet, the Cabinet passed the new health plan, the new roadmap that shows the way forward very clearly in relation to the future development of our health services. I know also what's keenly awaited are the reports from the two groups working on the smaller hospital framework and on the new hospital groups, which will work for a number of years before they become trusts. So if you like, this is a trial period to try out these new groups. Some of them are very obvious and work obviously well together. Some are a bit more fraught, and down this end of the country there are some issues which are currently being addressed. But I would like to say the following in finishing, and thank you very much for your patience and time in listening. I want to assure you that I am more committed than ever to the reform, that I'm more determined than ever to see it through. But more than any of that, I'm more convinced now than ever before that we will succeed, because of the new leadership that's emerging within the health service and across our health service. And nowhere is that new leadership more evident than in this room today. So I want to thank you all, assure you of my commitment to the ongoing reform, and hope that you have a great day examining the challenges that we face in primary care, and that you'll come up with more brilliant ideas to help forward the reforms that will improve the health of the nation and our people. Thank you very much.